It's already 3 minutes past our time, so we'll start it. Sorry for this technical trouble, but uh, I welcome you all for the third webinar of the WFNS Radiosurgery Secrets series. And for this webinar, we have a very special invitee, our dear friend Konstantin Tuleska. And I request my co-chair, Professor Selçuk Peker, to introduce our esteemed speaker today.
Thank you so much, and thank you to everyone for being here. And of course, we would like to thank so much to Konstantin Tuleska for accepting this invitation and being with us today. So for the short introduction for him, of course, all of us know him very well. And Konstantin Tuleska is currently working as a neurosurgeon, and he is working in Clinic de la Source and Swiss Medical Network in Lausanne, Switzerland, and he is also associate professor of neurosurgery at the University of Medicine and Pharmacy in Iași, Romania. And as a clinician scientist, he completed his neurosurgical training at Lausanne University Hospital in 2025 and complemented by 3 international fellowships: stereotactic radiosurgery in Marseille with Dr. Regis, intramedullary tumors and rare spinal malformations in Paris with Dr. Parker, and neuro-oncology spinal neurosurgery in Lille with Dr. Reins. Dr. Tuleska obtained his MD PhD from the University of Lausanne in 2018, receiving the Excellence Prize in 2019. He is Swiss board certified in neurosurgery since 2019, and he has authored or co-authored more than 160 peer-reviewed papers in leading scientific journals and served as a staff neurosurgeon at the public hospital in Lausanne between 2022 and 2025. His contributions have been recognized with several prestigious honors, including the Young Professional Award of the International Radiosurgery Society, ISRS, 2 distinctions from the French Academy of Medicine, and awards from the European Association of Neurosurgical Societies, EANS. He also served as a member of the ISRS board, and he is currently a member of the Radiosurgery and Frontiers panels in EANS. And we are very glad to have you, Konstantin, in this webinar series. And we are very excited to hear something about radiobiology of radiosurgery from you. Thank you so much for this presence here. Thank you.
Thank you for your kind introduction and for having me today. I much appreciate being involved in this series. And of course, I will speak about radiobiology. I don't consider myself a radiobiologist, so I will try to dissect this for our neurosurgical community. Let me try to see if I can share the screen up. So now, do you see me well?
We are able to see your screen.
But you have to change the screen to PowerPoint.
Okay, up. I think I'm a bad technical guy today. I don't know why. I usually am good in techniques. This is okay?
Perfect. This is perfect now.
Perfect.
And there is a latency period in radiosurgery, so it takes time sometimes for the technology.
Yeah, I think so. I probably have some circuitry which needs a restart, I think, no? Let's see. So I'm going to share a couple of thoughts on radiobiological principles of stereotactic radiosurgery, and I again thank you for having me today. I think we need to go back to history to understand what is our present in radiobiology. This slide mainly says that before radiosurgery appeared, we had dose fractions in radiation therapy. We had lesser risk of injury of normal tissue surrounding the target volume because, of course, you fractionated. And I think the initial radiobiological principles were mainly established by cell culture studies, particularly in malignant tumors, and the early clinical experience in radiation therapy. Now, the main thing is, and that's extremely important for us neurosurgeons, we usually do single high dose of radiation in stereotactic radiosurgery, which gives a radiobiological response depending on the target we are choosing. And I also think some of the radiobiological investigations were focused, as also the Legzel's investigation, Steiner investigation, Christer Lindquist investigations on the high dose focused on the CNS stereotactic radiosurgery in the 50s. If we go to some chronological evolution in desired effects of radiosurgery, as we all know, we had the nice gamma knife thalamotomies for pain, which was a focused necrotic lesion. It was a lesion. We can call it whatever we want to call it, but at that point, with very high doses, it was a lesion. Then we had destruction of pathological tissue in vestibular schwannomas. Of course, we all like these images where you treat a benign tumor or a malignant one, and finally, a couple of years later, a couple of months later, depending on the indication, you see a shrinkage. Then we had the angiography, and we have the obliteration of the AVM via proliferative vasculopathy. And this had actually been done by the early 70s, if you remember, because we had the angiography, but we didn't have the MRI. And then it evolved to local tumor control and to also the fancy non-lesional functional neurosurgery, neuromodulation, intrageminal neuralgia, epilepsy, psychiatric disorders, and so forth. Now, how do we quantify this? How do we measure radiobiology? How do we translate it in practice? I think to get into practical things, changes are coming from dose volume and also have a certain latency, so they are time dependent. If we go to dose volume histograms, we have here an example of the tumor control or AVM obliteration. And we all know that most effective dose for fractionated radiation therapy had been determined by these dose escalation studies, like in the glioma trials of the RTOG. Now, the thing is, in our field, in stereotactic radiosurgery, these have been determined through progressive dose reduction over time. If we forget about this slide, but if we go to history, we know that the first vestibular schwannoma treatments had been done by Legzel, prescribing 27 grays, and we finally de-escalate to 12 to 13, sometimes 14 grays in some centers, or 11 at the other lower level in others. So that's the curve we had in stereotactic radiosurgery. Of course, we have those related to local control. These are quite common papers nowadays. That's a paper from 2021 discussing local control in brain metastasis and showing curves which are again dose dependent. We were speaking about the dose dependency. And this is also, you can see here, this was a trial discussing those regimens by volume. Now, if we go to volumes, one of the most common volumetric curves in radiosurgery is the risk of secondary effects in arteriovenous malformation treatment. That's a slide I like very much because it's almost 30 years back and it's still on time. It's not overrated, it's not underrated. It's just on time 30 years later. You have here the correspondence of the prescribed dose, complication rates, and also this is related to the volume received by the 12 grays or more. We are speaking about the normal brain volume when we treat an arteriovenous malformation. And of course, this is by anatomical location. Now, if we go to time dependent, we have early and late radiation effects. Of course, immediate effects. I mean, we all know we treat patients with trigeminal neuralgia, which are getting pain freedom immediately. We have some quite quick mechanisms where you have patients becoming pain-free in the next days. We have also a nice phenomenon. That's a paper from Jean Regis discussing how seizures will disappear after an AVM treatment, although the AVM is still present, so far before the obliteration. And of course, we have late effects like radionecrosis in months to years, vascular stenosis, but that's exceptional. And we have cyst formation, for example, after AVM occlusion. So if we would have to establish a goal of radiation treatment and therapeutic ratio would be to maximize killing of the tumor or a pathological tissue, if that's the target, while minimizing the effect to the normal tissue. And you have this type of therapeutic ratio where you have local control versus toxicity, where you try to keep the good balance towards a fair radiobiological effect. And we cannot speak about radiobiology without getting into some of the practical aspects of radiobiology. I won't make a course on radiobiology. Iuliana Tomadasu, for example, is very much better than I am in this topic. But to sum up some of the basic things, I would say radiobiology, it's finally a study of how the action of ionizing radiation on living tissue would be. And that's biology, that's physics, that's epidemiology. And of course, the question is what's the balance between radiation and clinical consequences. If we go to phases of action, you have a physical phase, and you have a chemical phase, and you have a biological phase. And all this is scattering a certain amounts of time. If we go to physical interaction, it's mainly between radiation and molecules. You have possible biological damage, and you have certainly some effects of radiation caused by cellular depletion. If we further go to the chemical phase, that's of course what we like showing in our slides. It's how we will affect the DNA molecule, because that's the radiation induced cell killing working on the DNA finally. And of course, you have two types of damage. One is direct, the other is indirect. I won't get again into very complicated aspects. But we know that we have single double-strand DNA breaks, and we also have an important effect, and I think that's to retain from this part of my presentation. We have what is called the sublethal damage. I will get back to this when I will speak about the biologically effective dose. So this sublethal damage between isocentered treatments, between fractionated treatments, this would influence how tissue repair is being handled, how DNA changes are handled. Chemical phase, again, it's related to the DNA damage, which might be lethal or sublethal, with an impact on the cell clonogenic potential. And actually, we have also, again, the critical, extremely important, I repeat myself, sublethal DNA damage, which is extremely important for stereotactic radiosurgery. And that's more or less three scenarios for the DNA damage: correctly repaired, radiation protection with some cellular mutation, and we have cell death generated by radiation therapy. And this actually shows, again, different type of effects, how well oxygenated tissue are sensitive to radiation, and how some hypoxic tumors, for example, are radiation resistant. So oxygen is the most powerful radiosensitizers of the tumor cells, which we don't use, in my opinion, at his precise value, because we don't understand all these aspects in detail. Now, of course, survival fraction is a function of those. We had typical studies discussing 2 gray per day exposure, for example. And again, you can see anoxic aerobic versus aerated hypoxic curves, discussing how those would change some populations of cell and what is the exact shoulder of this. And we also know that DNA damage leads to a variety of chromosome aberration, and some of them are unstable and tend to be lethal. And so we would have some damaged cells dying at mitosis in what we call mitotic catastrophe, and finally apoptosis. So in most tumor cells, necrosis is being observed as least frequently as apoptosis. Now we have indirect effects of radiation. I won't get much into them. I think it's important to understand it's not one effect, it's a couple of effects. And that is why it's difficult to have a complete page on what's happening. Because you have a vascular effect, you have an immune effect, we have a bystander effect, which is the distance effect, and we have abscopal effects, tumor regression at distant sites, for example, from the irradiated volume in absence of any treatment. Of course, that's demonstrated, nice published papers in many journals. Now, of course, most of the radiation biology had been discussed on cell survival curves, and on clonogenic survival, cell survival experiments. You have one of the classic curves discussing this type of events. And of course, you have these nice cells you have here, and finally would have irradiated. And finally, the question is, what would be the best mathematical fit for cell curves in the lab? We speak about lab. That's curves established in the laboratory. That's not real patients. And we further go to the linear quadratic model, which of course tries to establish slopes of the cell survival curves. You have the alpha, you have the beta, and with these two, you can establish a ratio of alpha beta at which linear and quadratic components of these curves will cause an equal cell killing. Now, this is again a model, but the problem is different biological tissues will react in different manners to the same irradiation. So depending on your alpha beta, which mainly shows whether it's an early or late responding tissue, you can establish or anticipate a certain biological effect. And of course, again, that is to show curves for high alpha beta, like in brain mets, low alpha beta for benign tumors or AVMs. But there are also aspects which are important related to the cellular cycle. So the alpha beta cannot just blindly be applied because we have some other aspects. That's a paper discussing how cells were sensitive or not to radiation depending on the phase they are in. And of course, not all the cells will react the same, although they are irradiated in the same time. To go into the more clinical aspects, that's a paper from Jason Xian group, if I remember well, discussing outcomes in patients treated with brain metastases in the morning versus the afternoon. And those treated in the morning did substantially better due to these aspects related to cellular cycle and so forth. Now the question is, can we drive the alpha beta? And I would say we have a couple of papers on the alpha beta ratios, which are giving part of the truth, but not all the truth. That's a paper in the early 80s discussing brain necrosis after whole brain radiotherapy for an alpha beta of 2. That's a table of CNS toxicity depending on dose regimens and volume. And that's the optic pathway tolerance to radiosurgery, a paper which stayed as a dogma for years and years until the paper of Pollock came in 2013. One of the aspects is we have a couple of dogmas in radiation biology nowadays. One of the dogmas is dose rate. People in the gamma knife community are quite used to it because you just have dose rate decay during time due to cobalt decrease in radiation. Of course, we know the CyberKnife has a certain dose rate, ZAP has another dose rate. The common place for all of these things is treatment time. we cannot just separate those rates. We cannot just separate machines. That's not the discussion. We can discuss, of course, precision, other aspects, but radiobiologically, we need to discuss about treatment time, and that's the key community in this discussion on radiation biology. Now, people saying dose rate is relevant did a couple of studies. That's cell survival studies suggesting time is more relevant. You have here a study on the alpha beta of 10, alpha beta of 3, and the fact that normal tissues shows more change with the dose rate. But again, dose rate is time, treatment time, it's not just dose rate. And we have papers, we know these papers on trigeminal neuralgia, particularly discussing this paper, for example, no dose rate impact. That's a paper dating back into 2006. And of course, in 2010, with more or less the same message. And then we had a new paper from John Lee stating dose rate is relevant. But again, it's not dose rate. What we see, it's not necessarily what we want to see, in the sense that we see an impact of the dose rate, but dose rate is just the tip of the iceberg translated in time, treatment time. Mainly this paper shows that if you have a higher dose rate, you have less pain recurrence and you have higher immediate pain relief. And of course, this had been translated to vestibular schwannoma, discussing freedom from hearing loss, higher dose rate, less probability of keeping a functional hearing during time. And finally, 3 categories. The question is, why do we discuss meningioma tumor control, discussing different regimens of dose rates? 3 dose rates categories, why not 4, why not 5? Of course, if you push our statistician, we'll get even 7, 10, I don't know, and so forth. Now, the second dogma is that you would commonly hear, I currently have a paper on peer review, and one of the comments is, we know the alpha beta. No, we don't know it. I do apologize, but I respectfully disagree. People say everything, it's 2.47, although that is the so-called normal spinal cord alpha beta or normal brain. If you see the AVM, 0.6 to 6, that's huge. Meningioma, 2 to 6. Spinal cord, 1.6 to 5. Vestibular, 1.4 to 4. Mets, it's around 10. So now we don't know it. We think we know it. That's the only thing, but that's a dogma. We actually don't know it. And common paper in the literature, including mine's, discuss 2.47 as an alpha beta, because we are kind of forced to do it by these conventions that the BED, I'll get back to this, it's calculated based on the 2.47. Now, the linear quadratic model has mainly 4 categories of targets. You have the AVMs, late responding target in a late responding normal tissue, which is the brain. Then we have a meningioma, which is a benign tumor. So again, a late responding target surrounded by late responding normal tissue. And typically, if you have a meningioma in the cavernous sinus, you can deliver high doses of radiation. It's no problem. There will be a rate of complication extremely small. And we have the early responding targets embedded in late responding normal tissues, as typically an astrocytoma we treated in a single fraction. And we have early responding targets, that's brain mets, surrounded by late responding normal tissue, in which one might expect poor therapeutic ratio, which is actually not the case. And we have the 4 areas of radiobiology: reoxygenation, redistribution, repair, and repopulation. And of course, some people add a 5th, some people add a 6th, but the main, you have them here. In this context, we had John Hopewell discussing how we should get further from the linear quadratic model to apply it to radiosurgery. I think John did a pioneering work based on Fowler's appreciation on biologically effective dose, which finally, forget about this formula, it doesn't matter. It's concept embedding dose and time inside. It's what we need. You won't see the dose rate, by the way, in this BED model because it's not necessary. Why do we need the biologically effective dose? Because mainly if you have radiosurgery, which is single fraction, BED would rise more rapidly with the increasing of dose and will fall much more rapidly, faster with the biologically effective dose. And so we want to have now, but we are still at the beginning, a more, let's say, comprehensive model of what's happening inside the radiosurgical treatment. And we try to establish how we can pass from the physical dose you have here to the biologically effective dose, and how would this impact certain curves. And of course, you remember trigeminal neuralgia, the dose rate effect by John Lee. And now we have the biologically effective dose effect showing if one prescribes more BED, you pass from 5% hypoesthesia to almost 40% hypoesthesia rate. And of course, we did a study for discussing the thalamus in the sense of tremor, essential tremor treatments. You have correlation between clinical improvement and BED here. And again, shorter beam on time with better improvement. Again, we go back to the treatment time, which is the core radiobiological parameter. And in schwannomas, volumetric decrease as per BED, you have a linear relationship here. That was not a study on tumor control, but rather on how tumors would decrease with higher BED prescriptions. And then again, some curves modeling the BED with the treatment time. And you see these nice curves. That's a Gamma Knife paper discussing mainly how would influence tumor BED and tumor control on vestibular schwannomas. And some similarities between Doug Kondziolka's group, our group, on the influence on the hearing preservation and BED to the tumor. So this is the BED to the vestibular schwannoma. And again, treatment time, I'm obsessive with that. That's one of my best papers, I would say, if not the best maybe, in which we show that if treatment time increases, the risk of hearing decline increases. You have 3% per minute and you have 92% per 20 minutes. That's a huge change. So we discussed years and years about the dose to the cochlea, plenty of other parameters. Now we have that treatment time is involved in hearing preservation. So that's extremely important. And of course, BED on the cochlea, it's important. You have a paper showing mainly that if you go from less than 8 to more than 12 BED, you pass from 30% to 85% hearing loss. Major changes. Of course, that's also valid in pituitary adenomas, either secreting or non-secreting. That's a paper from Bruce Pollock's group showing that if you have an insulin-like growth factor index after treatment, measurable, you can actually quantify that a higher BED would be better for the treatment of acromegaly. And again, this is a paper on the AVM where we try to reproduce those curves versus BED curves, and you can see that we actually showed what it had been shown in the lab, that you have a higher increase in dose with a higher increase in BED, more than the increase of the dose in the curve. It's more exponential. And BED was the strongest prediction for obliteration, but also the treatment time, shorter treatment time. And of course, these findings had been further extrapolated in other studies. So biologically effective dose, it's a parameter which is getting more and more study. And of course, with the clinical application. So radiobiology is much more important than anything we did probably before. And that's probably what's going to bring us in this century in a better understanding of what we are doing. That's a paper on the alpha-beta ratio for melanoma brain metastasis, which we did with the team in St. Petersburg. And again, the treatment time or irradiation time, in this case, better for local control if it's a shorter treatment time, less than 20 minutes. So again, treatment time, both involved in hearing preservation, local tumor control, plenty of other aspects. Now, a couple of problems, because I'm being very critical to any model we have. I don't believe in modeling everything. BD is rat spinal cord and pig epidermidis driven, and I think we should not forget this. So these are mostly animal studies. We are now trying to extrapolate this on the human brain and human conditions. We should not take them as for granted, because it's a lot of things to do and many to reassess. So we should not take everything as it is presented, let's say it. Second thing, we should stop discussing the dose rate. I think some of the discussions we have is because we had the gamma knife community publishing a lot. We have new devices now getting into the market, which is very good. But this is getting into discussions on technical aspects. I think the discussions should stay on radiation precision, radiation safety, and treatment time. That's the most relevant, and to get more and more published data with all devices. A third limitation is that we have alpha-beta driven models. The question is, are they outcome specific? I don't think so. I mean, if we study vestibular schwannoma, brain mets whatsoever, you can fit a couple of alpha-beta ratio, you have a range, but you don't have really a value. You have it here, 12.4, between 9 to 19.3. That's enormous as variation. And that's a study we did in Lausanne discussing how BED is difficult to calculate voxel per voxel, because don't forget we need to calculate it voxel per voxel. It's errors up to 12%. That's, again, quite important. But again, we should continue doing it. We should continue calculating. That's a model discussed with Christian Kotrutz, who was a physicist in Lausanne. And we did a lot of work understanding how different formula would give different results, how calculating voxel per voxel would give different results. And of course, the question is, are these models correct? And the question also is, does this matter? I would say, yes, it does matter. Are these models correct? Probably yes. The problem is we don't see the whole. We see DNA damage isolated, immune cell response isolated, hypoxia isolated. We need to have the global picture, and the global picture is complicated. That's why biologically effective dose is complicated. So mainly we need to understand how to improve. We need to get the alpha-beta ratios. We need to understand what we do in multi-isocentric plans. What are the hotspots for a treatment? Would prior surgery influence? Would prior radiation influence? Prior chemotherapy? And the question is, we have plenty of equations. Of course, we have people saying this is the truth. Is this the truth or another dogma? That's the question. And the thing is, now if we go more and more and more, how do we measure the endpoints? Because we are medical doctors, so we are not isolated. We have patients to treat. So the patients are interested to understand, how do we understand what we are doing ourselves? It's not the same if we treat a trigeminal neuralgia, an AVM, or a vestibular schwannoma. The outcomes are not the same. Toxicity is not the same. So we need to get a better understanding on the endpoints we want to measure. This can be hearing, this can be tumor, this can be hormone level, this can be vessel. That's not the same. So this is pathology adapted. So radiobiology of radiosurgery is poorly understood, in my humble opinion. I think that's a very complicated domain. I think it defies the linear quadratic model, which comes from radiation oncology. We cannot simply translate this to neurosurgery and to stereotactic radiosurgery. And I think we are fundamentally different than fractionated approaches from radiation therapy and what is unfair called stereotactic radiation therapy, which is a little bit pushed. And of course, I think the biologically effective dose would be the key concept for the understanding of the radiosurgery, but we are far from getting it correctly and completely. So we need to get more and more models and further data. I need to thank a couple of people, Juliana Dasu, Alexandru Dasu, John Knisely, Christian Cotrut. They all helped me to get a clue on radiation biology. Juliana Dasu is the editor-in-chief of Physics Medica, and she's an extremely skilled physicist and radiobiologist. Same for Alexandru. John has another understanding which I don't have, and we shared a lot of data and a lot of discussions, and the same for Christian Kotrutz. Thank you for your time, and I would be glad to take questions.
Thank you, Konstantin. This was really a very good comprehensive review of your work, the work which you are actually dedicated yourself to. I've been listening it for quite a long time, so really excited to see you again. The house is open for discussion, so I invite the attendees, if they have any questions, they can actually put it in the chat box. Else, I have a couple of questions, and Dr. Selçuk has some questions. Yes, Dr. Selçuk.
Thank you so much, dear Konstantin. To listen to you when you give a conference on this subject is a pleasure for us, as always. When I listen to you in the conferences also, I do get a lot of pleasure from getting a lot of information from you. I have to open the discussions. May I ask you, we know that with giving high radiation to the tumor cells, we do affect the DNA of the tumor, and we stop the growth of the tumor, and then the tumor goes to necrosis or other results. But some authors claim that when we give high radiation to the tumor, actually we do affect the endothel of the intratumoral vessels, and through that damage of the vessels, the feeding of the tumor decreases, then the tumor goes to necrosis. What is your opinion about this discussion?
Yeah, thank you for this question. I'm smiling because many people, even neurosurgeons, would tell you there is no apoptosis. Some people don't believe in apoptosis after radiation neither. So that's quite a large topic. I think there is a vascular effect related to high dose of irradiation, to give you an answer. But I actually think there is a vascular effect also on lower doses. I think vascularity, it's impacted by radiation. And I think the theory in which there is a vascular effect accounting for tumor decrease, for example, it's extremely valuable, and I believe in it personally. Outside this, there are papers on the topic. There is one famous paper, which I think it was a Cell Press in 2015, 2012 or something, discussing what is the impact on the vascular part depending on those regimens. And that's a very, very, very powerful paper, because it's a mix between a lab and clinical paper. And it actually shows that this vascular effect, it's measurable and you can actually use it. And I think we don't use it as much as we should use it, because you have different data on the topic. Some believe it, some don't. Some think it's only on the higher dose regimens. I think it's on the whole dose regimens. And I think it's a button to modulate, but we don't have the key yet.
Thank you. Please go on, Manju.
Coming to the same question, if you think means a
Please,
very vascular
please,
tumor like
Manjul, before your question, Konstantin, can you stop sharing your screen? Then we will see you much more better than now.
Yeah.
Perfect. Thank you.
So we can now ask questions in the big screen. So Konstantin, it's coming to the same question of the vascularity. Like if you are treating a glomus, if you go in the literature, there is a huge range treating a glomus tumor, which is a highly vascular tumor. Some people are happy with 14 to 16 gray, and there are groups which are actually going more than 25 to 30 gray. So, and the groups which are actually doing with the higher dose, they show that there is no cranial neuropathy, which might be a side effect, but the tumors are responding very early because they are probably attacking the vasculature of the tumor.
Mm-hmm.
But,
I know the papers. Yeah, sorry, please.
but the same corollary is not true for a cavernous sinus hemangioma, which usually goes well with the 14 gray universally.
Yeah, but again, I think it's a question of level of vasculature, level of vessels. What do we have as angiogenesis? And it's not going to be the same in a benign tumor and in a malignant tumor as you evoked. If you see the published papers, I agree, in gliomas, for example, we claim nowadays we should prescribe more. But again, it's because we have a high rate of angiogenesis inside the tumor. I think in benign tumor, we have a similar effect, but with a lower rate of microvasculature, let's say. And that is why we don't need to have such high doses of radiation. That's one point. Second point is, I think, again, there is a vascular effect in all the tumors, whether we like it or not. And I think it's extremely underused in our perception because we focus on cell killing. I mean, I always tell my patients, I'm exaggerating, but I tell them, we are going to stop your tumor growing, we are going to inactivate cells, and then we see the MRI, it's more white, less white, we measure, we decide, and that's it. I think the vascular, and it was on several slides, I showed the vascular effect, it's extremely underanalyzed, and it's extremely powerful. And that's one of the key directions to advance, I think, in radiation biology. But again, I think it's in all type of tumors. And if I can give another example, because I saw a sixth nerve schwannoma on my consultation today, which we treated with radiosurgery, you have a shrinkage which is enormous in like 1 year. We don't see it in vestibular. It's still a schwannoma. It's still a nerve tumor. And again, I think that's a vascular effect. It's the same radiation dose, lower doses for a benign tumor.
But again, now since you talked about dose and the BED, and you showed three radiosurgery platforms: Gamma Knife, Cyber Knife, and ZAP, and the dose rate was so different in them. Do you think that with these machines, LINAC-based machines, we are making much hotter plan for the similar dose for these tumors?
You want me to get killed? This is recorded, right? So you want to try on my head. More seriously speaking, I think probably we did, let's start with the evidence. We did a comparison on the BED Cyber Knife versus Gamma Knife. And what we found, it's not very astonished. We had slight differences in the BED, but it was more homogeneous in the Cyber Knife plans than it was in the Gamma Knife plans. But that's not wow, because we know our hotspots with the Gamma Knife. Now, stating we need to be more homogeneous or less homogeneous depending on the platform, I don't think it's necessarily the target. I think the question more or less is to find the common parameter. This can be, for example, the BED corresponding to the 98% of the tumor coverage or of the AVM coverage. I'm giving ideas. So if anyone wants to do a paper on it, that's a good topic. Because finally, what's important, if you go, for example, to trigeminal neuralgia, to vestibular schwannoma, at a certain point, we were discussing the integral dose in the nerve, the integral dose in the tumor, how it's impact hearing. I think the BED is the same thing. I think the hotspot or the non-hotspot, it's the same thing. It's like an integral BED in a surface. If we have a CyberKnife, a ZAP, or a Gamma knife, and we treat a 1 cubic centimeter tumor, what would be the integral BED in that tumor? And how would these 3 platforms impact this integral BED, or the 90% tumor receiving how much of the BED, how this would impact hearing, and so forth and so forth. So again, I think the discussion on the hotspot or non-hotspot, homogeneous versus non-homogeneous, it's something which is not going to change in the next 20 years, because mainly Gamma knife would still be non-homogeneous dose inside, CyberKnife would still be homogeneous, LINAC-based platforms would still be homogeneous. Some of our colleagues would say, because they have a device, it's better like this. The others would say, nah, that's not normal. And I think, again, the common is an integral BED, something which is reported on the tumor surface, on the nerve surface. We had this on many, many, many conditions.
Probably we have one question.
Can I ask you, related to this question, you said that in Gamma knife it is not homogeneous treatment, so when we give same marginal doses with Gamma knife or other LINAC-based systems, but the central part of the tumor receives much more in Gamma knife. Can it be effective on the immunologic response of the tumor or the abscopal effect of the radiation to that tumor? Could it be some difference in the responses on these aspects?
Yeah, I think it is. We never published it, but I think it can have an impact on what you are saying. I would give you one example. There are many. At a certain point, I was seeing the patients with vestibular schwannoma on follow-up MRI, and some of them would have a more homogeneous necrotic pattern inside than the others. So I went back to the treatment plannings, but we never studied this in the frame of a study. And dosimetry was different inside the tumor. So the dose homogeneity was not the same whether you would have a compact necrosis inside, like following the shape of the tumor, versus some spots of necrosis around. So that's one thing. Second thing is that it was purely intuitive, but I don't know if you did it, but I did it, and Jarigis did it at a certain point. We were avoiding hotspots inside the internal acoustic meatus for a vestibular schwannoma, for example. So let me drive the discussion forward. So we avoid hotspots in the internal acoustic meatus, but the dose to the cochlea stays low. So why do we do it? Because we know we will engender a vascular effect probably around the tumor in the internal acoustic meatus on small vessels which go to the cochlea, which go to the labyrinth, and so forth. Otherwise, it was no need to do it. And we also knew that if we leave hotspots in the inner ear, this would increase the integral dose. This would increase the effects on the surrounding structure, although, again, the dose to the cochlea is still low. So this proves, these two examples, that both function, which is the second example, and tumor control are driven by some effects related to that.
Thank you. Please, Manjul. We have a question from our friends, please.
Yeah, it's by Dr. Narendra Kumar. Dr. Narendra Kumar is the professor of radiation therapy in PGI Chandigarh. He's my esteemed colleague and he's a part of the Gamma Knife team. So he has just put a comment rather than a question. And his comment is: direct and indirect killing is defined in terms of low and high linear energy transfer radiation for target DNA. However, in stereotactic radiosurgery, high-dose radiation in one go acts directly on vascular endothelial and leads to its disruption, so it's direct action, not indirect.
Okay, I have 2 comments on your comment. Thank you for this comment. So, first, depends on what we decide as high dose radiation. What is high dose radiation? Is it 20 grays in METs, or is 130 grays in a capsulotomy, thalamotomy, or whatsoever? That's not the same, for sure. Of course, if you prescribe 20 grays in a brain mets or 24 grays in a melanoma brain mets, for example, you would have exactly what you are saying, a direct effect. Now, if we go to a psychiatric treatment, that's an extremely nice field in development nowadays, and you do a capsulotomy, nothing really happens immediately. So, and those more than 8 gray you commented. Yeah, okay. So I would say, to answer directly, you're right. Yeah, more than 8 gray as high dose. Yeah, I understand your comment, but that's classification depending on papers and many things. I would rather transfer this into 2 separate ideas. One is treating a tumor, or even 3 different ideas. Treating a tumor at 20 gray, a brain mets. This would be exactly what you are saying, probably direct effect on the vascular endothelium. Okay. Now we prescribe 24 in a mesiotemporal lobe epilepsy. How do we account this? That's more or less the same dose on brain normal tissue. Not normal, sometimes abnormal, but still it's not a tumor. And third, we do a capsulotomy for an OCD, 130, 140, 160. So I think, again, and I said it in one of my slides, that it's much depending on what do we target. What's our goal? What do we want from the treatment? Of course, in a mesiotemporal lobe epilepsy, you have some areas of dysplasia or whatsoever. But you sometimes don't have even important changes. If you go to a tumor, it's clear you want to kill it, you want to kill the cells, you want to make it decrease faster, not to go into the OR with it. But if you do a capsulotomy, then the vascular effect, it's probably there, but it's much more subtle. And one of the question is, why do we have selective actions on molecules, for example, in mesiotemporal lobe epilepsy, or you have selective actions on tracts, fiber tracts. So I think it's, your statement is true if we treat something which I would define as a tumor with a dose more than 8 grays, and I would agree with it. If we go to different pathologies, particularly in functional, I think the circuitry is much more important than the vascular effect. But there is a vascular effect also in my, I hope I answered your comment.
Mm-hmm.
You told something about oxygenation, and do you think that oxygenation is making a change once you are treating a metastasis in a preoperative setting versus metastasis you are treating in a postoperative setting?
I think yes. That is why we do so many studies on meds. Should we radiate before we go in the OR? Should we radiate after we go to the OR? And we spent like how many, 20 years discussing tumor bed treatments versus preoperative brain med treatment before the surgery. So yeah, I think that makes a difference. And I think we realized it's not making only a local effect, but you have all these papers on the leptomeningeal spread, depending on the timing of the irradiation. And that also shows distant effects of radiosurgery and of tumors. And again, timing, it's important, that's for sure. So yeah, I think it's a topic where we have not finished yet the understanding of what we are doing.
Konstantin, do you recommend an oxygen line while we are treating the patient?
No, we never did it. I never do it. But I was thinking at a certain point. The thing is, if you want to do this, the ethical committee would probably state you have a psychiatric problem. So we will need to find a psychiatrist stating we are normal before we launch this. And then it would probably be difficult to publish. But I wanted to do this at a certain point. I think some of the developments in radiosurgery would be either on the radiosensitizer side, but that's extremely powerful but complicated, but also on the oxygenation side. How do we change local tissue oxygenation? And of course, radiosensitizers, but that's an extremely large topic. I read a little bit what had been published recently on vestibular schwannoma and getting back to papers like 30 years ago. You have papers discussing 5 types of different vestibular schwannomas, or discussing 2 types, which is more common. But again, how do we account this? So probably we would have one day a powerful chat GPT will place 1,000 papers inside. We will tell him, listen, that's the information, get out what's relevant, and we will arrive with the big data to get more insight.
There is a lot more fractionation now happening with all these machines. So what should be the minimum interval between the 2 fractions once you are treating something with this stereotactic radiosurgery, the time interval?
That's an open question because this, let's say, resides in several answers. The first one, it's my evidence-based answer because I'm functioning like this. We know that if we do hypofractionation, for example, it's 5 every day. It's what is commonly accepted. Now, in some centers, you hear we make a break on Wednesday. The question is why? Because we are closed. So we start next Monday, the last one. Okay. In some centers, they say we are not treating on Friday. So the Friday it's skipped on Monday. So again, that's human-based protocols. I think what we have nowadays established, at least for hypofractionation, it's every day. Some of the people say it should be weeks apart. I don't think we have the understanding of it, but I think the evidence-based current state of the art is every day for the 5 fractions at least. That's what we have as the data published. Of course, we can do it differently, but we need to get blood tests or something which would change our comprehension and say, okay, now we are doing it every day. If we do it every 2 days or every week or every month, what would be the impact? And then you need to do blood samples, MRIs. So you need an amount of data to cover this to see what's the best fitting. That would be probably an idea to get more data on the hypofractionated regimens.
Since many of our colleagues are practicing spine radiosurgery, so do you think in your opinion, how is a spine different radiobiologically in comparison to brain? If you can just say it in some simple words, what do we need to be aware of it?
I would say, it's funny you asked this question because I didn't do spine radiosurgery for a couple of years, for many years. And in 2022, after 12 years of radiosurgery, I was wondering what's different in spine. I think in spine we have a couple of topics which are extremely relevant. First is it was a game changer for the Mets. That's the first thing to state. We all acknowledge this. I am doing spine surgery now quite a lot, and I think it has been a game changer. It's still a game changer. Second, I think the spinal cord tolerance, it's not something to play with, because if you do one mistake, it's finished. So I think spine, it's a little bit like the optic pathways in the brain. We stay more on the conservative side than on the aggressive side, which is perfectly normal. And third, I think spine radiosurgery is still underused benign lesion. As an example, we can take many. Are residual tumor, for example, after resection, a spine root schwannoma, if you are close to a branch of the Adamkiewicz artery, for example, or something in which if you do an aggressive surgery, it might turn into a paraplegia. So you can do an intracapsular decompression as you would do it in the brain and combine the treatments. That would be a next game changer. Another one is, for example, in hemangiomas. You have people having local pain. They are never treated. They go on and on and on and on and on. Or they have aggressive resections. That's no need. We have radiosurgery. So I think the third field would be benign tumors. We should expand more. Subtotal resection should expand more for benign, and new indication rising, including hemangiomas and other tumors.
They say that probably brain has some series and spine runs in parallel circuits.
I like this.
Probably hitting some small part that's going to have a huge impact on the spine radiosurgery. That's why you are asking us to be a little cautious about it.
Yeah.
Konstantin, you talked about the uncertainties about the BED calculation because we are not sure about the alpha-beta ratio of each tumor. And we also know that in some tumors, there's a difference between some parts of the tumors. Alpha-beta ratio is something here and something in other part of the tumor. So to compare the studies about BED, the alpha-beta ratio of the tumors, etc. Today is not so so precise. So it is not easy to trust to every study because they may accept, for example, you may work on meningiomas, you can accept alpha-beta ratio as 2.40 something. Then I can accept alpha-beta ratio for a meningioma 6. So our results will be different. The complication, the effect on complication or the tumor control. So how we can solve this problem? What is your thought about it?
So the short answer would be modeling and modelization on large amount of data. That's one answer. I will get back to this, but the short answer is this. A much longer answer would be if you take vestibular schwannomas, some people would say that different cell lines in vestibular, at least two, would have two different alpha-beta ratio, one which is much higher than the other. So even what we see and we think it's a vestibular would not be really a vestibular, or not exactly this. That's one comment. Second comment. I think the discussion on the alpha-beta, it's passing in inflection point currently. I have a paper on meningiomas in BED. It was one of my master's student theses, and one of the comments of the reviewer is why we choose 2.47. And I wanted to answer him because I didn't have a choice. Because if you don't choose 2.47, a group of people, I won't give names, would kill you in the next letter to the editor, stating you didn't understand what is the radiobiology. Okay. I don't need to understand what is radiobiology as a radiobiologist. I just need to punch it in my clinical practice and get better my patients. So this 2.47 starts to get on my nerves, but also I needed to get to adapt to it because we don't have a choice. So for the moment, there is so much dogma on the topic that no one would hear another opinion. We are like in the Inquisition times. You say differently, you get burned, okay? And the third answer is if we model these alpha betas, and I try to do it in vestibular. I have a paper on vestibular schwannomas discussing hotspots of BED as per alpha beta. And I can tell you they are all statistically significant from 1 to 6 for tumor control, which is crazy. And finally, it's more or less the same curve for the whole alpha beta spectrum. This means that the linear quadratic model is completely non-applicable for radiosurgery if you take 300 vestibular schwannomas, as I did, and you don't find one which is the sweet spot. And to tell you more, I submitted this paper to a review. I didn't respond to the reviews because I wanted to submit it to another one, get other reviews, and then I'm in the third review now just to have fun and see what the other people say. So it's still unpublished. Yesterday was the first time they sent me the paper back because I didn't answer. They didn't understand. I don't want to publish that paper for the moment. I just want to get a clue, people interaction on the topic. And I think, I mean, we did it with the statistician. It's solid analysis. It's not me playing with the data. We don't know. And it's all statistically significant. I can tell you from 1 to 6.
Interesting. Thank you so much. Thank you.
If there is no more questions, I would like to close the session because we are already more than 70 minutes now. Probably somebody has a question to somebody else. Okay,
Thank you so much, Konstantin. It was a feast for us. Thank you.
Likewise here. Thank you so much for having me. It was a pleasure to see you.
See you somewhere face to face.
In Istanbul soon. We meet at the same event. I'm much looking forward.
Please.
Take care.
Bye-bye. Thank you so much.
Thank you so much. Thank you.
Bye.
Thank you. Bye.
Thank you all.
Thank you. Thank you for attending it. Soon it would be on WFNS channel.